In this video, I'm going to talk about chelating metals. Metals make up about 75% of all the elements, from gold, copper, and silver coins and jewelry in 10,000 BC, to the Bronze and Iron Age for tools and weapons, to the electronics, batteries, and thousands of uses we have for them today. Metals are everywhere, including our bodies, and that's a problem. Metals create free radicals, leading to accelerated aging. They misfold proteins into prions, creating brain damage and senility. They have catalytic effects, causing bizarre chemical reactions to happen in our bodies, like turning the lipids in our cells into hydrogenated Crisco. We have natural processes to remove metals, such as metallothioneins, glutathione, albumin, and lactoferrin, but they can only do so much. Once the metal detoxifiers become overwhelmed, metals get stored in the lysosomes. Once the lysosomes get stuffed with toxic metals, our entire protein recycling system goes offline, and the overflow of worn-out proteins combined with metals we can't remove, and they get stored or turn into a toxic glue that's deposited all over the body, causing accelerated aging and disease. Amyloid plaque in the brain is one such example. So we need a way to remove these metals. The process is called chelation, but if we do it wrong, it's worse than ineffective, it's dangerous. We can end up moving metals around the body from places that aren't so bad, like fat cells in the abdomen, into places that are much worse, like the brain. This is called redistribution. In this video, I'm going to explain which chelators to consider for which metals, so you can support the body in safely and effectively removing them. While natural chelators like citric acid were discovered in the 1700s, it wasn't until 1935 that EDTA, the first effective chemical chelator, was discovered. But EDTA does not make extremely strong bonds with several metals and can cause redistribution. So over the next 90 years, scientists worked on creating better and better chelators. We now have chelators that are both safe and effective and can go into both the water and lipid compartments of the body. But these chelators remain relatively unknown outside of the labs of the people who are working with them. The knowledge of their existence and how they work, as well as even their availability to practitioners who might know about them, has been extremely limited until now. In this talk, I'm going to teach you about three of the most advanced chelators we have today: DOTA, DOTA-MC12, and MIA-DMSA. This isn't for theoretical purposes. I'm also making them available as liposomal preparations. But before we get to protocols, I want to explain why I've chosen these over all the others. I've prepared some reference tables you can download from the link in the description at the bottom of this video. If you want a deep understanding of the science of chelation, print these out and you can reference them. If you just want a working knowledge of how to chelate properly, then all you need is the chelation reference page. For each metal that we may need to detoxify, we need to find out which chelator is best. This means knowing which chelator makes both a fast and strong bond with the metal. If the bond is too weak, it can grab the metal, but then let it go again before it is removed from the body via the urine or feces. This is called redistribution, and we must avoid this, or at least minimize it. If the bond, on the other hand, is too strong, which is typically rare, it can grab onto the metal, but then turn it into an insoluble compound that forms nanoparticles, crystals, or liposomes that are even harder to remove. The measurement of the strength of the bond is called the log K stability constant. A stability constant under 20 risks redistribution, and over 30 risks nanoparticle, crystal, or liposome self-assembly. Higher log K constants also slows the speed of the attachment of the chelator to the metal, and it also inhibits our ability to use active transport in the kidneys and liver to excrete them. We'll talk more about this in a moment. So I like to see a log K somewhere between 22 and 25 if possible. Several things affect the log K of a specific chelator with a specific metal. Let's talk about 7 of the more important ones. First, the number of bonds a metal can make. This is called its coordination number. A metal's coordination number can change depending what kind of chelator it is bonding to. 2, the number of bonding sites that a chelator has to bind to the metal. This is called its denticity, and each bonding site is called a dentate. Chelation works best when the chelator has a denticity equal to or greater than the metal's coordination number. That is, the number of bonding sites on the chelator is equal to or greater than the number of bonding sites of the metal. If it's the other way around and there's more bonding sites on the metal than on the chelator, then not only is the bond unnecessarily weak, but it is still toxic and can react in the body. Number 3 is the hard, borderline, or soft characteristics of the metal. Metals with small ionic radii and strong charges are called hard. Metals with larger ionic radii and weaker charges are called soft, and borderline metals are a little of both. The kind of dentates that a chelator has is also important. COOH carboxy dentates are better with hard metals, NH2 amines are better with borderline metals, and SH thiols are better with soft metals. CH3 methyl groups are not dentates, even though sometimes people refer to them as chelators. What they do is they help push water away from the chelation metal complex, which stabilizes the chelator. Number 5, the shape of the chelator. If it is a string, that is called linear. If it is a ring, it is called a macrocyclic. The macrocyclic chelators must match the size of their cavity to the metal, which leads us to the ionic radius, which is the functional size of the metal atom. The combination of the size of the macrocyclic chelator cavity and the ionic radius of the metal gives us the steric fit. If the steric fit of a macrocyclic chelator and a metal are good, meaning the metal fits snugly into the metal cavity, it's not too big or too small, then the bond is very strong. If not, it may be better to use a more flexible linear chelator. Finally, pH, that is, how acidic or alkaline we are, matters. Each chelator has an optimal pH range it works in. Combining these factors gives us a value called the stability constant for a particular metal chelator mix. These stability constants are shown on the chelation reference page. Now let's talk about how this table is set up. At the top you have the 4 chelators, DOTA, DOTAM-C12, MIA-DMSA, and EDTA. While EDTA is no longer suggested for most metals, it is the chelator of choice for plutonium and thallium-3+, so it's in this table as well. DOTA and EDTA are water-soluble, while DOTAM-C12 and MIA-DMSA are both lipid and water-soluble. The term for something that is both lipid and water-soluble is amphipathic. That being said, DOTAM-C12 and MIA-DMSA are more lipid-soluble than water-soluble at about a 60 to 40% ratio. In addition to the stability constant, we also have the KON association constant, which is the speed with which a chelator makes a bond to a metal. The KON association constant is affected by the chelator metal match, that is, matching a soft metal with a soft chelator, when this will give you a higher KON association constant than mismatching metals to chelators. The KON association constant is lower for the 2 DOTA macrocycle chelators than it is for the linear EDTA and MIA-DMSA chelators. This is because the more stable ring shape of these macrocyclic chelators also makes it a little slower for them to grab the metals. It is a trade-off, stability for speed. This is important to know in the case of acute metal poisonings where a faster KON association constant is more important than a stronger log K stability constant. That being said, you can certainly stack both together in a case of acute poisoning. We'll talk more about how to accelerate or increase the KON association constant in the protocol section in a moment, as well as explain what the blue, green, black, and red colors represent. While metals can and will go everywhere, it is the intercellular spaces in the brain where they do their worst damage. It's important to have a lipid-soluble chelator for each metal because that's the only way to get the chelator inside the cells or past the blood-brain barrier. EDTA and DOTA are both water-soluble and so cannot pass intact cell membranes or the blood-brain barrier. However, DOTAM-C12 and MIA-DMSA are lipid-soluble and can. Okay, we've talked science. Now let's talk protocol and application. In order to know what chelators to give and not to give someone, we need to know what metals they have. Options include analysis of hair, urine, blood, skin, medical interview, and test by fire. The benefits of hair are that they are an average over 3 months and do not require a challenge chelator which can injure some sensitive patients. The downside is that you need to recognize the pattern that indicates a false negative for mercury, which shows up as deranged mineral transports of nutritional metals, such as calcium, sodium, magnesium, potassium, and zinc. To learn this in more depth, study the works of Dr. Cutler. The benefits of urine are that you can do a challenge test where you give someone one or more chelators and see what comes out of them. The downside is that it will not show what is excreted by bile into feces, and you must use multiple chelators to get a full sense, which can make sensitive clients react poorly. The benefit of blood over urine is that the kidney and fecal route question is bypassed. The downside is that it still requires challenge chelators and is invasive. Both urine and blood tests are also unreliable in the sense that if someone were to have, say, a tuna fish sandwich before the test, it could show a spike in mercury that is not indicative of a true mercury load. The benefits of a photospectrographic skin analysis are that it is immediate and non-invasive. The downside is that the company currently offering this has declined to do any tissue studies to validate their reference standards. Since this is an extremely easy thing to do, it is suspicious. With all laboratory testing, please note some labs cannot distinguish between the F-block elements and report them all as uranium. It is important, at a minimum, to have a lab test that can distinguish between uranium and gadolinium. The benefit of a medical interview is that there are no expensive tests. The downside is that a patient may have exposure that they are unaware of. Finally, you have test by fire, where you give individual chelators to a client and see what kind of improvement or reactions they have. This kind of testing is not recommended. Once you know what kind of metals you are dealing with, you must consider which is the best chelator or combination of chelators. Take a look at the chelation reference page now. The blue numbers represent a good choice. The green numbers represent an acceptable choice, but not necessarily the best. The black numbers represent the best of a bunch of bad options, and red is a no-go as it will cause redistribution. You are already likely familiar with the risks of mercury redistribution. However, redistribution can happen with any metal. Using a soft metal chelator with a hard metal, or a hard metal chelator with a soft metal, can also cause this problem, which is why you see red no-go values for the soft chelator MIA DMSA with the hard metals like aluminum, gadolinium, and barium. But what if a person needs to detoxify both hard and soft metals at the same time? In this case, we must combine chelators so that there is always a chelator with a high log K to protect against redistribution from a chelator with a low log K for any particular metal. Remember, the log K is the stability constant. Okay, how do we start? First, it's important to check urine pH with fresh pH strips or a properly calibrated pH meter. Keep in mind, pH strips become inaccurate relatively quickly after they are opened. For each chelator, there is an optimal pH for it to bind with metals. However, we must also remember that if we go too acidic, some metals like cadmium, lead, and aluminum combine with sulfates, phosphates, or oxalates and precipitate as nanocrystals. On the other hand, if we go too alkaline, some metals like lead, manganese, and barium can form nanocrystals with hydroxides or carbonates. So finding chelators that are active at physiologic pH is important, and one of the many reasons why I focus on DOTA, DOTAM, and MIA DMSA. For these chelators, a urine pH of 7.5 to 8.0 is optimal. A slight alkalinity will neutralize excess hydrogen protons in the body. This is important because protons act like metal and can competitively bond to chelators, making the chelators less effective and more likely to redistribute. Specifically, protons in solutions have 6 negative outcomes in terms of chelation. 1, they decrease the KON association constant, making it slower for chelators to bond to other metals. 2, they decrease the log K stability constant, increasing the risk of redistribution. 3, they make metals less soluble, so they are more difficult for the kidneys to excrete. 4, they increase the risk of having metals that do leave the kidneys get reabsorbed back into the bloodstream again. This is the kidney's version of enterohepatic recirculation. 5, they increase the risk of metals that enter the kidneys bonding to kidney tissue and damaging it. And 6, they increase the risk of metals forming nanocrystals and eventually kidney stones. For soft metals that require SH thiols, aim for a urine pH of 8.0. Below 7.0, thiols lose their effectiveness. For borderline metals that require NH2 amines, aim for a urine pH of 8.0. Below 6.0, and amines lose their effectiveness. For hard metals that require carboxyl groups, aim for a urine pH of 7.5. Below 6.0, carboxyls lose their effectiveness. Do not let urine pH go over 8.0 or you may end up precipitating metals in the kidneys. While you can take baking soda to raise body and urine pH, this will neutralize stomach acids and can weaken digestion. If you want to take bicarbonates to manipulate and shift the urine pH towards the proper values, consider our bicarbonate product, which opens up in the small intestine and not the stomach. The small intestine is where our livers and pancreases secrete bicarbonate, so this way we are working with the natural pH shifts of the body and digestion and not against it. All right, let's talk about the actual chelation. We begin by clearing out the water compartments of the body, those being the blood, lymph, and connective tissue. With the exceptions of plutonium and thallium-3, for which we use EDTA, for the water phase of the detox, we will always consider starting with DOTA. Always do the water compartments before the lipid compartments, or the intercellular and brain areas. This ensures that the intercellular spaces and the brain have a higher concentration of metals than the water compartments. This gradient decreases redistribution risk from the water compartments back into the brain and intercellular spaces. Consider doing the water phase for at least 3 months, or 1 month past the last improvement in symptoms. Once you get to the lipid phase, do not switch. Rather, add in equal amounts of your chosen lipid-soluble chelator. Then, once every 3 to 5 days, do only the water-soluble chelator. This helps reinstate the concentration gradient and decreases the risk of redistribution into the brain. For the lipid-soluble phase of the detox, for arsenic and mercury, consider MIA-DMSA. For all other metals, consider DOTAM-C12. In terms of dosage, it is a balance. Too much in the kidneys and liver cannot keep up, and you get symptoms of over-detoxification. Too little and you won't get the concentration levels needed for optimum chelation, and the protocol can take longer than needed. Always begin with half a capsule, then slowly work up to no more than 500 milligrams of total chelator per day. Chelate-bound metals must leave via the kidneys or bile and then feces. As such, there are a few considerations. To support bile flow, consider glytamins. To support kidney function, consider staying well hydrated with reverse osmosis water. We must also minimize enterohepatic recirculation, which is when toxins enter the intestines with the bile and then are reabsorbed at the distal small intestine back into the bloodstream. To do this, consider 2 tablespoons of organic psyllium with juice every morning. It must be organic since there is a loophole that allows for dangerous levels of pesticides in non-organic psyllium. You can also support the liver and kidneys with glandulars, and in the case of the kidneys, CoQ10. Now, if you wish, take a look at the chart that shows the elimination route for unchelated metals. From this, you can deduce which organs may have been damaged by the body, naturally trying to remove metals on its own. Remember, anytime you see damage to the liver from metals, the microbiome is also likely impacted. As a side note, if you are dealing with aluminum and not gadolinium, consider choline-stabilized orthosilicic acid. The product is called BioSil. I will explain more about aluminum detox in another video, but conceptually, orthosilicic acid may help solubilize the aluminum so it can be chelated more easily. Now let's talk about some supportive protocols. Chelation causes mineral losses. For DOTA and DOTAM, consider zinc, iron, and copper. For MIA-DMSA, consider zinc, selenium, and copper. For EDTA, consider calcium, magnesium, zinc, and iron. That being said, many people have too much copper and iron anyway, so check their levels first before supplementing. Also, mineral supplements should be given at least 12 hours away from chelation to avoid competition with the toxic metals for the chelation dentates. We also have endogenous chelators and supplements like glutathione and alpha-lipoic acid. These are listed in the reference materials. Do not give these during chelation as they will lower the KON association constant for the chelators by being competition, and this can trigger redistribution. Now we need to talk about metals that resist chelation by forming crystals, nanoparticles, and liposomes inside the body. Once metals are in these forms, they are much more resistant to being chelated. Also, since these forms are over the 6 nanometer pore size of the kidney, they cannot be urinated out. Because the liver only has active transport, the upper limit for biliary excretion is even smaller at 1.2 nanometers. Molecules above this size are often retained in the liver. I personally believe that when you see fatty liver on an ultrasound, what may be happening is that the liver is taking these accumulated large toxins and shuttling them or storing them in globules of fat that it generates in the liver to protect the liver cells. We will need a way to disrupt these forms when doing chelation to make them available to be chelated, and also to allow them to be removed by the kidneys and liver. This may be accomplished with pulsed negative voltage. For already formed crystals, pulsed negative voltage can shatter crystals due to the piezoelectric effect. You may wish to consider our electron charger on the pulse setting. For actively forming crystals, excess electrons promotes dendritic or branching structures over smooth crystal layers. Dendritic crystal structures are easier to chelate due to their higher surface area and looser atomic packing. For liposomes, electrostatic forces can destabilize vesicle curvature, prevent proper biliary closure, as well as cause compression forces in the liposome itself. By pulsing electrons into liposomes, loss of curvature and compressionary forces can shatter them, making the metals inside them available once again for chelation. This also suggests that oil and fat consumption should be limited during chelation so that mobilized metals do not form liposomes. Regarding nanoparticles, negative electron voltage reduces nanoparticle agglomerations and can stabilize them as colloidal suspensions due to increased zeta potential. This makes them easier to chelate due to higher surface area and weaker bonds. Proper placement of the electron charger pad is on the feet to support pulling the positive charged toxic metals in the brain as far from the brain as possible towards the negative pole being created at the feet. It should be noted here that our electron charger should never be used when there are any medical devices in the body, and this includes stents in the blood vessels. Now, how do we increase the KON association constant we mentioned earlier? Imagine you have a flask of water with some powder in it that is slowly dissolving. How might you accelerate the rate at which it dissolves? Well, you could shake it up and you could heat it. That's why in laboratories there are heated magnetic stirrers, because movement and temperature increase the rate of chemical reactions. How might we do this with a human person? In terms of heating, you can consider a sauna. A 1 degree Fahrenheit rise in temperature will increase the association constant from 6 to 10%. So if you could get 5 degrees warmer than normal, that's a 30 to 50% increase. It goes both ways, however. If you have a low body temperature, then for each degree you are colder than normal, that's a loss of 6 to 10% in effectiveness of chelation. So it's important to be warm. In terms of shaking the flask, you could consider a whole body vibration technology operating at 26 Hertz. Caveat: saunas open up the blood-brain barrier, so only use them during the brain phase, the detox. Also, when we sweat, our intestines also sweat, so it's important to take binders for the toxins that are released into the small intestine. I should also mention dosing on the half-life. This was made popular by Dr. Cutler as a way to minimize redistribution, where you took a series of chelations on the half-life to keep the concentration levels up. The higher the concentration, the higher the KON association constant, and the less likely you are to get redistribution. The chelators Dr. Cutler had access to were prone to redistribution events, especially alpha-lipoic acid. However, now that we have chelators with much better stability constants, redistribution is less of a concern, and half-life dosing is less of an issue. However, it is a way to further increase or maintain KON association constants, so I mention it here for your consideration. That being said, the half-life of chelators varies tremendously from person to person. Water-soluble chelators are typically cleared in a few hours, but lipid-soluble chelators take longer. That being said, if someone has compromised kidney or liver function, half-lives can be much longer still. It's also important to repair the organs damaged by metals. For the brain especially, consider our Nervidyne product, especially with mercury, as mercury demyelinates the nerves. In the last 80 years, we've made a lot of progress in our understanding of metal toxicity, as well as having invented safer and more effective chelators. If you're looking to support your body or those of your clients who have metal toxicity, our Captamet product contains DOTA, our Dasamet product contains MIA-DMSA, and our Dotamet product contains DOTA-MC12. If you have any questions, feel free to contact us. Take care.